left, we can start sharing the. Roughly, I think we are 9:30. We can start at any time.
Okay. So can I have the slides of the?
You want me to share my screen now?
Just a minute.
Yes. Then I will introduce you first.
Okay, I'll share my screen.
So good morning, everyone, for staying back and joining us on this Saturday morning. We have very renowned speakers from Australia, Professor Terence O'Brien, who is the Chair of Medicine in Neurology and Head of Central Clinical Schools in Monash Universities. He is also a Program Director from Alfred Brain and Deputy Director of Research in Alfred Health. He was formerly the University of Melbourne James Stewart Chair of Medicine and Head of the Department of Medicine in the Royal Melbourne Hospitals, as well as Warren Clefroth Chair of Neuroscience at Monash Universities and the Director of Neurology at Alfred Health. He is specialized in neurology and clinical pharmacology with particular expertise in epilepsy and neurodegenerative diseases, preclinical and clinical trials, as well as in vivo imaging in animal models and humans. He has published more than 535 peer-reviewed original papers in leading scientific and medical journals, which has been cited up to 21,000 times with a H index of 76. And he is currently the president of the Epilepsy Society of Australia. So we would like to invite him today to speak to us on translational epilepsy research addressing the treatment gaps. I'll pass the time to Professor Terence O'Brien.
Thank you very much, Professor Lim. I hope everybody can hear me. Welcome to everybody wherever you are in Malaysia or around the world. I'm sorry we all can't be here in one space together, but at least with Zoom technology, we could connect ourselves across the globe. I thank everybody for giving the time to listen to me for the next hour or so, and we'll have some time at the end for some discussion. And thank you to the Farouk and the organisers for putting on such an outstanding program and inviting me to be part of it. So this morning, I'm going to be talking about translational epilepsy research, and particularly how we focus our basic science and translational research in epilepsy to address the really many key treatment gaps in our current therapy for people with epilepsy. And it really builds on a story about the fact that even though there's been a lot of new therapies for epilepsy over particularly the last 3 decades, but really over the last 100 years, that have really not made a fundamental difference to the absolute key, gaps in care, and that we need to look at different paradigms to refocus our translational research towards actually addressing these gaps of care and developing new and improved treatment options that achieve this. And I'm a clinical neurologist. I see patients with epilepsy. I spent yesterday afternoon seeing about 25 patients with epilepsy, but I'm also a basic scientist and I have a basic science lab. And hopefully that puts me in a good position to be able to direct our basic science to what I see in the clinic as the needs of my patients. So just to remind everybody of the obvious, anti-seizure medications, or what we used to call anti-epileptic drugs, but that was a misnomer, are drugs which decrease the frequency and or severity of seizures in people with epilepsy. They are symptomatic treatments. They suppress the symptoms of epilepsy, which are the seizures, while you're taking the drugs, but they do not do anything to the underlying epileptic state or epileptic condition in any sustained manner. They can't prevent epilepsy. they can't modify its severity, and they can't reverse it. And as a result, since the epileptic state is in most patients a long-standing state and often a lifelong state, the medications need to be taken over a long period of time, often for a lifetime, which firstly opens up the issues of problems with medication adherence and compliance, and secondly opens up the issues of potential long-term complications. And we are now realising some of these, including osteoporosis, increased fractures risk, and metabolic effects. Over the last, as I mentioned in my introduction, in some ways we're lucky in the epilepsy field, as since the 1860s with the introduction of bromides, we actually have had effective symptomatic treatments for epilepsy that have been able to control the seizures in a good proportion of people with epilepsy. And over the last decade, there's this famous diagram that was adapted from my friend and colleague Patrick Kwan's PhD thesis with Martin Brodie in Glasgow in the late 1990s and 2000s, shows that over the last 3 decades, there's been an explosion of new anti-epileptic medications, over 20. Have these medications made a difference to our patients with epilepsy? Well, certainly they've increased the therapeutic options we have. However, multiple randomized controlled trials in newly treated epilepsies and also in add-on and substitution therapy have failed to show a clear overall efficacy advantage in the proportion of patients who achieve seizure control with the new anti-epileptic medications. And I'll come back to that in a couple of slides. Some studies have reported improved tolerability and retention, such as lamotrigine on the SANAD trials, but others, in fact, have failed to demonstrate this advantage. As I mentioned earlier, they do have the advantage of providing increased choice. And so one of the things that we're able to do with patients with epilepsy is cycle through more medications, and there's a greater chance we'll find one that the patient tolerates. And maybe we might find one that works a bit better overall in that particular patient. They have less pharmacokinetic interactions in some of the cases, which is an advantage in the older patients who are on multiple other medications. A really important issue in women with epilepsy who need to keep taking anti-epileptic drugs to prevent the major risks of seizures to them, their unborn child, and to other children and to society in general. The older medications, particularly valproate, we now realise are associated with an increased risk of birth defects and even neurocognitive problems in the unborn child. At least 2 of the new anti-epileptic medications, lamotrigine and levetiracetam, have been established to be safer in pregnancy. And so this is an important advance for women with epilepsy. Now, we're getting back to the efficacy, because at the end of the day, as I'll show you in a few slides, the goal of treatment with epilepsy, the number one goal is to control seizures and have seizure freedom, ideally with a therapy that causes minimal side effects. So this is, I alluded to my friend and colleague, and there's a young Patrick Kwan. He looks a bit older than that now, but he won't tell me exactly how old he is, but certainly older than this picture. When he was a PhD student in Martin Brodie's laboratory or group in Canada, he published this famous paper in the New England Journal of Medicine, which when they looked at the records of the more than 2 decades of patients from the, 2 decades of patients from the Glasgow Infirmary in terms of how newly treated patients with epilepsy had responded, they showed about 47% of patients had seizure control with the first medication trial, about another 13% with the second monotherapy. But after that, you're on a really major curve of diminishing returns, with very few patients, no matter how many different combinations or in monotherapy or polytherapy, actually having sustained long-term seizure freedom. 36% continuing to have uncontrolled seizures. So, as is our want to send our next generation back to repeat what our experiences, he sent his then PhD student, now postdoc, and it's not unpublished in an old slide. This slide was published in JAMA Neurology a couple of years ago. But Ben Chen went back and repeated the analysis, but this time in the era of the new anti-epileptic medications. And if you flick back and forth between these 2 pie charts, you see that big red section of the pie of patients with uncontrolled epilepsy essentially hasn't changed despite the era of new anti-epileptic medications. And this is also from Ben's paper, and this is the correct citation in JAMA Neurology. What he showed, what he is plotting here is over the 3 decades or 4 decades, 3 decades of this study, a change in the trend of prescribing of anti-epileptic medications. So in the earlier part of the cohort, carbamazepine and valproate, to a lesser extent phenytoin, were the major medications prescribed. Where in the more recent times, the last decade, that switched across to lamotrigine, carbazine, gabapentin, levetiracetam, topiramate, etc., with the earlier 2 drugs being a much lower proportion of the cohort. But, and this is the money slide, again, when you look at the probability of attaining seizure freedom in 3 different decades in the eras of different anti-epileptic medications, you see that that has absolutely not shifted at all. So we really have made virtually no, if any, impact overall in the proportion of patients who have drug-resistant epilepsy. So along with Aristide Ganalopoulou and Jackie French and Michele Simonoto from Italy, we've been since 2013 chairing a joint task force of the American Epilepsy Society and the International League Against Epilepsy, trying to redress translational research to address these gaps in care. And our first job, which we met with a group of about 60 experts in both basic science and clinical medicine in London before the London European Conference, to identify what were the major gaps in our therapeutic care of patients with epilepsy. And the 4 big gaps we came up with were drug-resistant epilepsy, which I've talked about, medication tolerability, with up to 80% of patients having side effects from their medications and a third of patients having significant side effects. And again, this has only modestly improved in the era of the new anti-epileptic medications. Lack of anti-epileptic drugs that can prevent epilepsy or disease-modifying drugs that can make it less severe or reverse it. Very important specific treatments for comorbidities. More than 2/3 of patients with drug-resistant epilepsy have significant comorbidities, particularly psychiatric and neurocognitive. And that is now recognised to be an inherent part of the epilepsy, not just something that happens because of the epilepsy. And in fact, you do see it, as I'll show in my talk, you do see comorbidities, these neurocognitive comorbidities in animal models of chronic epilepsy, indicating they're an integral part of the whole epilepsy disease. But I would argue that of these four key gaps in care, the one that is actually central to them all is the lack of anti-epileptic or disease-modifying treatments. And the reason is that if we were able to be effective in identifying a true anti-epileptic or disease-modifying drug, we would actually improve the other 3. So a true anti-epileptic treatment can either prevent the development of epilepsy after something like a traumatic brain injury or a genetic mutation, or it could potentially reverse and cure the epilepsy. However, even if it doesn't, as I'll show in a slide or two, even if it doesn't completely reverse the epilepsy, just making the epilepsy less severe may result in less drug resistance. And I'll argue that in fact, the key to developing true treatments that are effective in drug-resistant epilepsy is actually to develop disease-modifying therapies. If you've got a less severe epilepsy, you'll require less anti-epileptic medications and you're less likely to have side effects. And so the tolerability factor will also be improved. And given what I said before about the understanding that the epilepsy substrate is a major cause of the psychiatric and neurocognitive comorbidities, if you're able to modify the underlying substrate or prevent the epilepsy occurring in the first place, you'll also positively impact the psychiatric and neurocognitive comorbidities. So that's why that is I believe, the key goal of translational research, and it certainly has been in our group. And the other point I want to make is, and I always say this to my patients when I see them, that our goal with you is to make you seizure free, not just reduce your seizures by 50%, has been the endpoint for most new anti-epileptic drug trials, because that doesn't fundamentally change your life, but making you seizure free does. Seizure freedom is the outcome that has most consistently been shown to be associated with improved quality of life in patients treated either medically or surgically. Drug-resistant epilepsy, where there's not seizure freedom, has an increased incidence of injury, increased incidence of death, both accidental and also sudden unexplained death or unexpected death in epilepsy. Greater medication burden with adverse effects and financial costs, increased psychiatric comorbidities, greater socioeconomic disadvantage, being unable to drive, limitations in work, stigma, etc., and overall reduced quality of life. Just to put some dollars around this, Emma Foster, who's a young neurologist and just submitted a PhD student in our group with Patrick Klein at the Alfred and Monash, and Zanfina Andami, who is a health economist who works closely with us, led a study where they looked at the cost of epilepsy in Australia. And they did life modelling with 2017 data from the Australian Bureau of Statistics and the Australian National Health Survey and the World Bank. They modelled productivity and mortality outcomes in working age Australians from 15 to 69 years of age. They assumed that 70% of the cohort members achieved seizure-free status, which is probably a conservative estimate, because even though drug-resistant epilepsy, as we said before, is about 30% or more, there's many patients who don't take their medications properly, and so actually the proportion that actually seizure-free is probably less than that. But using this, they calculated that epilepsy costs working age Australians an enormous more than 14,000 excess deaths, almost 80,000 years life lost, almost 150,000 productivity adjusted life years or PALYs, and lost GDP to Australia of $32 billion. And just to focus the discussion on improved treatments, if we were able to reduce seizure freedom or improve seizure freedom by 5% from its current 70% up to 75%, they modelled that there would be more than $50 million reduction in direct healthcare costs, let alone the indirect costs, prevention of over 800 excess deaths, almost 4,000 years of life gain, and more than 17,000 PALYs saved, equating to almost $4 billion in GDP savings. So this shows what a bit of investment in improved therapies for epilepsy could actually do for health economy in Australia. And imagine if you extrapolate Australia as a little country when it comes to population, you extrapolate this to the globe, and it's an enormous healthcare benefit. So a potentially very worthwhile investment. So I want to come back to this concept of drug-resistant epilepsy being a reflection of disease severity. This is an emerging concept. Not everybody completely embraces it, but to me, it makes a lot of intuitive sense, and it is a good way of understanding why those 20 or more new anti-epileptic drugs over the last 3 decades have really not made any significant impact on the proportion of drug-resistant epilepsy, despite the fact they have a variety of different mechanisms. And each new drug that comes out, the marketing people like to say, well, this has got a new mechanism, does this, does X, and none of the other drugs have done. So therefore, it's going to have a better spectrum of action. And in fact, that doesn't turn out to be the case. And that's because, in my view at least, what you really need to do to reduce the incidence of drug-resistant epilepsy is to make the epilepsy less severe, modify the severity of the epileptic substrate that causes the epilepsy. And by doing this along the blue line, if you have a very, very effective disease-modifying treatment, you may actually completely reverse the epilepsy and have a cure. Now, that's obviously a holy grail and may not be achievable with medical therapy. But even if you're able to reduce the severity to a partial degree, while you may not have a complete remission of the epilepsy, you may be able to transform someone's drug-resistant epilepsy into drug-responsive epilepsy. And we know this is a proof of concept from epilepsy surgery because it is the one actual disease-modifying therapy that you do have for epilepsy. Epilepsy surgery, where the underlying epileptic zone or the bulk of it is identified through the pre-surgical evaluation and surgically excised, as in this case with temporal lobe epilepsy, sometimes results in a complete cure, no drug, no seizures. But in many cases, and we actually, when we counsel people about surgeries, we don't use the C word, we use the disease-modifying word, and that you have drug-resistant seizure we can't control despite all these medications we're giving you. But if you have successful surgery, we will hopefully be able to control your seizures with a small dose of maybe a single medication. So what you're actually doing is taking it from drug-resistant to drug-responsive epilepsy, reducing the medication burden, and it's been well shown now by longer follow-up studies that they reduce psychiatric comorbidities. Along with that, if someone achieves seizure freedom following epilepsy surgery, they have improved quality of life, improved patient satisfaction, improved employments and independence, decreased injury, hospitalisation, and critically death rates, decreased cost of care to the community. So that's great for people who can have epilepsy surgery, but probably a conservative estimate, only 5% of all drug-resistant epilepsies are good candidates for epilepsy surgery where there's a clearly identified epileptic substrate that can be safely and successfully removed. And there still are a proportion of patients, even in the best scenarios of lesional epilepsy, maybe 20%, who do continue to have drug-resistant seizures following surgery. So the challenge for disease-modifying medical therapies is to achieve what we can achieve with epilepsy surgery, but in patients who are not able to have epilepsy surgery. And that is the holy grail of translational research, for those who love Monty Python. So I'm going to talk a little bit conceptually about epileptogenesis and disease modification, so it's clear what we're talking about. Epileptogenesis is a dynamic process. It's not a single binary variable. And it almost certainly involves multiple different cellular processes that work in concert to ultimately develop a situation where a person or animal develops spontaneous recurrent seizures. Starts with an insult, which is either genetic or acquired, such as TBI, or a genetic mutation, such as a SCN1A mutation. There's a latent period, which things happen in the brain, neurobiological things happen in the brain, which cause epileptogenesis. And then the first seizure occurs, and then ultimately further seizures occur, and you evolve into the chronic epilepsy state. And alongside that, you have markers of disease progression, increased seizures, drug resistance, neuronal loss, neuropsychiatric and psychiatric comorbidities. So disease-modifying therapy can work at a number of these phases. It can act as a preventative medication. So you give it after, say, a TBI or genetic test that demonstrates a sodium channel mutation, and it prevents the development of epilepsy. And that's what generally people refer to as anti-epileptogenic therapy. You could give it after the first seizures occurred, and it slows down the progression into chronic drug-resistant epilepsy. Or the most applicable phase is you've got someone who presents with chronic epilepsy, and that's usually the people we see in our epilepsy centres, and it's able to reverse or mitigate the severity of established epilepsy, as with epilepsy surgery. So all three of these are important, but they're different, and they may involve different processes and different targets required to achieve the therapeutic goal at each of these stages. So bringing it back to why we haven't moved the ball down the field nearly as far with epilepsy therapies as we need to, we really believe that a lot of this is that we've been stuck in the wrong paradigm for anti-epileptic drug discovery. It's essentially the same paradigm since the 1940s when American Putnam discovered Dilantin, phenytoin. And look, it has been very effective with identifying anti-seizure drugs, so not to completely dismiss it, but it hasn't moved beyond that. Essentially, the paradigm is that multiple different compounds are screened across different types of acute seizure models. Most commonly, the maximal electrode shock therapy or the PDZ therapy, where either electric shock or a toxin is given to induce seizures in the animals, and then you test them with your test compound, and you look to see which compounds reduce the threshold or increase the threshold for inducing seizures, and then you take that through the drug development pipeline. This has been very effective in, as I said, in identifying anti-seizure drugs, but not in developing drugs against disease, medication-resistant or disease-modifying therapies. So what we're now refocused the field on is to move away from these acute seizure models and do testing in true epilepsy models. And what we mean by true epilepsy models are animals who actually have epilepsy, either by acquired or genetic means. They have recurrent spontaneous seizures, and along with that, you see many of the comorbidities that you see in epilepsy, and ideally they have drug-resistant seizures. And also that you start doing not just the way the paradigm has gone before. It's been test your test drug versus vehicle control. If the drug's anti-seizure, then you take it through a clinical development pathway where you do the same thing. In the preclinical world, there has been very little studies that have looked at head-to-head comparisons. In other words, does your new drug, do this any better than the established drugs in your animal models? And if it doesn't, then why would you take it through the whole clinical development paradigm? Because likely at the end, you'll just have another me too drug in terms of its endpoint, but not of its mechanisms. And very few of the preclinical therapy historically has been directed towards where the gaps in care are. It's much been more about identifying a drug as anti-seizure, and then let's get it through to market as quickly as we can, and then market the hell out of it. So that's why I again come back to this emphasis that true animal models are absolutely key to advancing therapies in the preclinical space. And I want to use an example, not to suggest in any way that I've got the gold standard new drug for epilepsy, but rather showing an example of how we can utilize true epilepsy models to test disease-modifying therapies, both in anti-epileptogenesis, then subsequently in disease modification. So I'm going to talk about a drug that modifies hyperphosphorylated tau. Now, any of you who've got interest in Alzheimer's disease or neurodegenerative diseases or post-concussive problems will know about tau because it's implicated in a variety of neurodegenerative diseases in its hyperphosphorylated state. Tau is a very important component of axons, axonal transport, and exists in a very tightly controlled homeostasis between its dephosphorylated state, where it's a structural protein in microtubules, and its phosphorylated state, where when it becomes excessively dysphorylated, it forms toxic tangles, and these are neurodegenerative. This homeostasis is tightly controlled by kinases, which dephosphorylate tau, which phosphorylate tau, and proteases, particularly PP2A, which dephosphorylate tau. Neurodegenerative diseases and brain injuries activate these kinases and also suppress PP2A, pushing the homeostatic paradigm towards accumulation of toxic phospho-tau. This drug, sodium selenate, which is an oxidase form of selenium, was found by our collaborators more than a decade ago in the Department of Surgery to be very, very effective at activating the main brain phosphatase that dephosphorylates tau, PP2A. And in a whole variety of neurodegenerative models driven by hyperphosphorylated tau, it dephosphorylates the tau and is neuroprotective and disease modifying. So we tested in our group whether this drug would be anti-epileptogenic in a variety of epilepsy models: the amygdala kindling model, the post-canic acid status model, and the post-fluid percussion injury TBI model. Now, just for time's sake, I'll focus on the latter, the post-traumatic epilepsy model. So post-traumatic epilepsy is one of the more common causes of acquired epilepsy and acquired drug-resistant epilepsy in the community. It occurs in about up to 20% of people after a severe TBI, but about up to about 8% following a mild TBI. It's about 5% of all epilepsies and starts in a window of 3 to 24 months post-injury, which gives an opportunity for an anti-epileptic therapy to be applied before the epilepsy actually manifests. And that window of opportunity is one of the reasons why this post-TBI epilepsy has been a focus of anti-epileptic therapy development. It's a chronic disabling condition, requires lifelong treatments, commonly drug-resistant, difficult to control, and it's associated with significant psychiatric comorbidities and psychosocial disabilities. And at the moment, we have no treatment that is effective in preventing it. After a brain injury, our standard anti-epileptic medications do nothing to prevent the long-term epileptic state. It's also an area where there are very well-developed models of traumatic brain injury, and one that has been best characterised for inducing post-traumatic epilepsy is the fluid percussion rat model, which is the one that we've been using in our group primarily. Essentially, a piston delivers a fluid percussion pulse through a luer lock burr hole in the skull, and it induces both a diffuse injury across the brain as well as a local injury where the fluid percussion injury has been applied. And that way, very nicely recapitulates what you see in a closed injury, such as a traumatic motor vehicle accident, where you have a local contusion as well as a diffuse contra-curing injury. And it has been well, as I said before, it's been well characterised that about 20-30% of rats followed 6 to 12 months following a fluid percussion injury, if you do chronic EEG recordings, will have spontaneous recurrent seizures, which look very much like the sort of seizures that we see in humans with post-traumatic epilepsy, both on the EEG and on the video. So we did a clinical trial in this model, essentially a clinical trial or preclinical trial, but set up like you do a clinical trial of epileptogenesis. We randomized rats to receive 3 months of 16 weeks of treatment with either sodium selenate via a constant infusion from an osmotic pump, or infused with vehicle. The analysis and all the studies were done blinded, and serial MRI scans and behavioural testing during the treatment period. Then there was a 2-week washout, and sodium selenate was a very short half-life in rats. And then we did another 2 weeks of video EEG to see whether there had been a sustained change in the manifestations of the seizures. We also looked at when the animals were sacrificed. We looked at the deposition of hyperphosphorylated tau, and you can see in the vehicle-treated injured rats, there was a significant elevation in the brain deposition of hyperphosphorylated tau, as you would expect, compared to the control rats. But those injured rats who had been treated with sodium selenate, that was prevented, so they essentially had brain tau levels like as you would see in a non-injured rat, which indicates the drug was biochemically effective in doing what we had wanted it to. When you look at seizures, firstly looking at seizure frequency and then seizure duration, in the pre-washout period, the last 2 weeks of the infusion, you see that the animals who were treated with vehicle, PBS, had a little over 1 seizure per day on average, where the animals who were treated with sodium selenate had about half that number, and the duration of seizures was also less in the animals who were treated with sodium selenate. The very important time period, though, of that post-washout time, after 2 weeks without drug, another 2 weeks of EEG recording, you see that the animals who had been treated with vehicle, both of them were untreated at this point, the time they had the recording, there had been an increase in the number of seizures that they were having to more than 2 a day, which reflects the progression you see in this model. But there was even more significant difference in the number of seizures per day that the rats who had been treated with sodium selenate were experiencing, reflecting this sustained disease modification of the manifestation of seizures. not significant, but also a trend for those seizures when they occurred to be less in duration. We also looked at MRI scan as a measure of brain damage and neurodegeneration. And what you see over time following the percussion injury is a progression in the cortical atrophy and the hippocampal atrophy and the dilation of ventricular size to accommodate for this in the vehicle-treated injured rats. These are sham rats who are the same at each point. And the selenate-treated rats were not the same as the sham-injured rats, but were significantly better in terms of the amount of brain atrophy they had compared to the vehicle-treated injured rats, demonstrating that the sodium selenate was effective in mitigating some of the neurodegeneration saw following brain injury. We also looked at cognitive effects. Cognitive problems, I said, were very common in post-traumatic epilepsy. We did this using a Morris water maze, which is a very commonly used behavioural test for cognition in experimental epilepsy, experimental neurobehaviour. You put a rat into a pool with coloured water so they can't see a hidden platform. They swim around and eventually they find that hidden platform. Rats don't like being wet, so they jump out of it and onto the platform. You put them back again and they remember, if they've got a normal intact memory, they remember where the platform is and they, with each successive trial, swim there quicker. So if you look at the sham-injured rats, both with vehicle and selenate, with each repeated trial, the time it takes them to find the platform and jump out is significantly shorter. When you look at the injured rats, they took longer to find in the first place and they never really improved. So their memory for where that platform was significantly impaired post-brain injury. The selenate-treated injured rats, they weren't quite the same as the sham rats, but they were able to learn much better than the vehicle-treated injured rats, indicating the drug not only had an effect on seizures and neurodegeneration on the MRI, but also had an effect on neurocognition. So that's indicated that treatment with a drug like sodium selenate is able to mitigate the severity of the epileptic state as disease prevention. But what about disease modification? And there's been many studies that have looked at different treatment modalities as disease prevention following brain injury or other insults. Very few that have looked at in the stage where the animals actually have chronic epilepsy. And this, as I mentioned earlier, is when our patients usually present. And so the opportunity to apply this in clinical practice is much larger than disease prevention. And it's also going to be an easier group of patients to actually do studies on that require following the patients less long and a higher proportion of them already have epilepsy. So it's going to be the power and the number of subjects you need is a lot less. However, there's some critical questions I alluded before. Are the neurobiological processes responsible for the development of epilepsy the same processes that are responsible for maintaining it in the chronic state? And therefore, does the pharmacological targets that are effective in preventing epilepsy, like as I've showed with sodium selenate, also effective in disease modification? So to look at this, we've particularly used the post-canic acid status epilepticus model, which is, I think, the best validated model of chronic temporal lobe epilepsy. The way it works is you give animals canic acid. You can also do it with electrical status or pilocarpine. They go into sustained status epilepticus for at least 4 hours and you stop it with diazepam. They have a latent period and then they start after 4 to 6 weeks or so having spontaneous recurrent seizures, which gradually increase in frequency and severity over the next few months. And these seizures are drug resistant. They are predominantly non-convulsive seizures like focal impaired awareness seizures, but they also are convulsive seizures. And when you look at the histopathology, it is very similar to what we see in human mesial temporal lobe epilepsy. And they have, along with the epilepsy, they also have neuropsychiatric and neurocognitive comorbidities. So again, we did a, led by Pablo Casillas Espinosa in our group, we did a trial of disease modification in this animal model. And what Pablo and his team did was take epileptic rats 10 weeks after canic acid treatment, implanted them with EEG, who had been implanted with EEG treatment to record the baseline frequency of seizures, and then treated them for a month with continuous infusion of sodium selenate, compared it with levetiracetam as a comparator. I mentioned the important head-to-head studies, and with vehicle and with a sham group, and then followed these rats in washout 18 weeks, 20 and 22 weeks post-treatment, and tested behaviour and tissue collection. Just to summarise some of the data from this, which is still unpublished and will be submitted very shortly. If you look at the vehicle-treated rats, during the various time points post-treatment, you get an increase in the average number of seizures per day. And this is the natural history of this epilepsy model. When you look at animals treated with levetiracetam, you see that the treatment period suppresses the seizures, and then once the treatment is withdrawn, they gradually start having more seizures again. However, those treated with sodium selenate, you find that even after the treatment has stopped, the number of seizures these animals expressing significantly decreased, and to the fact that even some of them were completely seizure-free at 8 weeks post-treatment. Pablo and his team also looked at neurocognition, but this time using a slightly different paradigm, and for time's sake, I won't spend a lot of time explaining this, but essentially what you do is you look at how often a rat recognises a novel object or a novel placement of an object in an open space. And with the post-status epilepticus vehicle-treated rats and the levetiracetam-treated rats, they had a discrimination index which indicates poor memory that was significantly greater than the vehicle, the sham injured rats. And the sodium selenate rats in both cases were much more like the sham injured rats, indicating they preserved neurocognition. Now, sodium selenate is a drug. There's no point just showing this nice results, disease-modifying results in animals. You need to be able to translate in humans. And one advantage of sodium selenate is it's already been in clinical trials led by our group and others in various neurodegenerative diseases. This is a trial that was done in Alzheimer's disease, showing some disease modification on diffusion tensor MRI in 6 months of treatment in Alzheimer's disease, and also demonstrating it's safe and well tolerated. However, showing these sort of disease-modifying treatments in animals is more difficult in humans. It requires longer study designs, particularly anti-epileptogenic therapies, where you need to follow the people for 12 or even 24 months before a proportion develop epilepsy. And that's much more difficult than the anti-seizure treatments that clinical trials that have been done to develop the drugs that we all use in practice. And we know from many other fields, stroke, TBI, motor neuron disease, etc., that many positive results in animal models don't translate into positive clinical trials. So this has been the goal of a NIH-funded Centres Without Walls that I've been part of, which is now into its 5th year. This is the EpiBios for Treatment, a consortium which involves centres in the US and centres in Finland and in Melbourne. And these are the PIs of this project, of this collaboration. It has 3 projects, 2 are preclinical and 1 is clinical. The 2 preclinical studies are looking at defining biomarkers of epileptogenesis and also screening potential anti-epileptic therapies, of which sodium selenate is one of them. And the human study is also identifying biomarkers. But the goal of this study being ultimately that we'll be able to identify a patient group who are more likely than 20% to develop epilepsy and target therapies to this group. So just to conclude, the traditional drug development paradigm for epilepsy has been highly successful in delivering multiple new anti-seizure drugs, but these have delivered relatively limited clinical advantages over the older drugs. Developing treatments that address the current gaps in epilepsy treatment research needs to be a fundamental goal of translational research. And this needs to focus on anti-epileptogenesis or disease modification. We have evidence from chronic epilepsy model studies, as I've just shown you, that this is possible. But preclinical and clinical trials are longer and more labour intensive and more expensive. And so we want a higher level of evidence from our preclinical studies before moving to clinical trials. And this has been one of the goals of our Epivirus for Treatment project. And hopefully within the next 6 to 12 months, we'll have data from that to present to the epilepsy community and move the goal of improved epilepsy therapy down the field further. So without listing everyone, just to acknowledge the many people from my group and our collaborators who are involved in the work that I presented today. And thank you all for your attention.
Thank you so much, Professor Terry O'Brien, for the very clear and comprehensive talks on the translational medicines. There are currently a few questions, if you can see that as well in under the Q&A bar. We'll go through some of them. And the first one, talking about drug-resistant epilepsy, the question is, what can we do? And is there the alternative to cure or prevent them?
Yeah. So I'll start at the back point. We don't have any way to prevent drug-resistant epilepsy at the moment. And that's why we need to be doing this translational research to identify and then ultimately do clinical trials for therapies that are effective in preventing or modifying drug-resistant epilepsy. Of course, we all see patients with drug-resistant epilepsy every day, and in the absence of anti-epileptic therapies, we need to have a strategy about how to do the best we can in the current environment. What I say to medical students and general neurologists and GPs when I talk to them about drug-resistant epilepsy, I say the first thing to do is recognise that when you've tried 2 drugs, it's time to refer to a comprehensive epilepsy centre, because as Patrick Kwan's work has shown, after those 2 drugs, if you keep cycling through more drugs, the chances you're going to render someone seizure-free is very small. And they may be someone who are eligible and a good candidate for epilepsy surgery. And the earlier epilepsy surgery can be done in drug-resistant epilepsy, likely the more effective it will be, but more importantly, the years of quality of life that are saved are significant. So one of the real goals in the field is to recognise earlier drug-resistant epilepsy and evaluate for epilepsy surgery and do epilepsy surgery earlier. So to fail 2 drugs, you need to refer into a centre that can do a comprehensive evaluation and consider epilepsy surgery. That's the most important takeaway point. The other point is that some patients may actually, who appear to have drug-resistant epilepsy, may in fact have something else. About 30% of patients who we monitor in our monitoring unit who appear to have drug-resistant epilepsy turn out to have, as their ongoing disabling seizure type, non-epileptic seizures, particularly functional seizures, psychogenic seizures. So obviously there's a whole different paradigm for that, for treatment for that group of patients, and you want to identify that before you're cycling through multiple ineffective drugs. There's also patients who you actually got the wrong epilepsy syndrome. You think they've got a focal epilepsy, they've actually got a generalized epilepsy, and you're treating with drugs that are not effective in generalized epilepsy. And the fourth reason that drugs may appear to be drug resistant is the patient may appear to be drug resistant is when they're actually not taking their drugs as they need to be. And non-adherence is incredibly common in epilepsy practice.
Yes, this is very practical questions and answers to many of those who are still practicing. The following are rather related to your talk. The first one is on relationship between epilepsy and Alzheimer's on the common pathological features. Is there a common pathological features?
Yeah, no, there are, absolutely. If you look at hippocampi of patients with Alzheimer's disease, they show a lot of the same hallmarks that we see in chronic mesial-temporal lobe epilepsy. And it's actually this, and they also show tau-based pathology and it's actually this that got me interested in Alzheimer's and other neurodegenerative disease in the first place. And we now realise, now we're looking for it a lot more, that in fact epilepsy is incredibly common in older people and incredibly common in patients with Alzheimer's disease. It's grossly underdiagnosed, partially because these patients are generally not seen by epileptologists. They're often seen by GPs, geriatricians, who are not attuned to diagnosing non-convulsive seizures. They often present with non-convulsive rather than convulsive seizures. And in someone who's already got an altered cognitive state, episodes of confusion are often missed or misdiagnosed as being sundowning or some other dementia-related problem. So yes, look, I think there is a lot of overlap between epilepsy and Alzheimer's disease, and it might be the same therapies that are effective as disease-modifying therapy in Alzheimer's disease may also be effective in acquired epilepsy, and that's an area of active research.
So follow up on that answers. So is it because of that's why selenite was chosen, because it's used in Alzheimer's as well?
Yes, so partly, yeah, you're right. So it was the selenite was the people who discovered it, Chris Hovens, when he's actually a urological researcher, and they were interested in cancer, and they were screening protease from cancer, and they found this very effective inhibition of PP2A, and they did their homework and they saw, oh, this is involved in tau, and tau is involved in Alzheimer's disease and frontotemporal dementia and PSP and other neurodegenerative diseases. So they went down that line. We shared a building, and I heard them do a talk, and I said, well, actually, this is probably also important in acquired epilepsy because we know that the pathologies overlap, and so that's how we started to look at it in epilepsy. So yes, it was because of that interest in neurodegenerative and Alzheimer's diseases that we then started looking at selenite in epilepsy.
Yeah, because the next questions will be related to that as well, is on cholinergic drugs. And in fact, beside the anticholinergic treatments in Alzheimer's, there are other treatments like NMDA, like memantine and so on. Are all these going to be anti-epileptogenic also?
Well, the first thing to say is they're not disease-modifying therapy in Alzheimer's disease either. So if they're not in Alzheimer's disease, they're probably not going to be in epilepsy. They are very much symptomatic treatments. They are, the idea is they're replacing cholinergic deficits or other deficits in neurochemicals that are present in patients with Alzheimer's disease. And the other truth about them is that they are only modestly effective even as symptomatic treatments. So if they were to have any symptomatic benefit in epilepsy, it would purely be symptomatic. And I'm not aware of anyone who's systematically trialed them, but they're not likely to be anti-epileptogenic because they are disease modifying in Alzheimer's disease.
Actually, talking about selenite, the last question is on the clinical trial. Has there been any clinical trial?
So we have started we've done a small clinical trial in Alzheimer's disease. We are just starting at the moment. We've got funding from the Australian government to do a randomised double-blind controlled trial in frontotemporal dementia, which in about 45% of cases is a tauopathy, and also in progressive supranuclear palsy, which is also a tauopathy. We haven't yet started a clinical trial in epilepsy. The plan is that would follow on from the EpiBios study. The first phase of the EpiBios study was to screen several different types of treatment, and selenite was one of them. And as a result of that, we are now moved into a multi-centre preclinical study involving over 180 rats randomised to selenite or vehicle, treated for 3 months and then followed for 6 months. And if that across 4 laboratories, and if that demonstrates confirms the sort of findings that I showed you earlier, then the plan would be to move from that into a clinical trial. So hasn't started yet. That's the next step following the EpiBios study.
I mean, because just to add on, did selenite go through all the animal epilepsy models that you use to test other AD as well, like pilocarpine and other animal models?
Pilocarpine is just another. Yeah, pilocarpine is just another way of inducing the status. In my view, it's actually the status that is the critical thing that induces the epileptic changes. So whether it's pilocarpine or whether it's canic acid or whether it's self-sustained electrical status, it really doesn't matter. They all produce ultimately a chronic temporal lobe epilepsy pattern in the rats. So I see that there's a question: what's the translational success rate from animal models of epilepsy to clinical success? So this is what I talked about very briefly at the end, the loss in translation. In many fields, that translation has been poor. TBI, motor neuron disease, stroke. But in fact, in most of those cases, if you look back at the preclinical studies that were used to inform the clinical trials, they were very poorly done, often not blinded, small numbers, all the sort of study quality things that we do in rigorous clinical trials weren't applied. So one of the things we're doing in the EpiBias study is in the preclinical study have very rigorous study quality like you would do in a clinical trial. But in fact, in the epilepsy field, the translation from animal models to humans has been incredibly good. All of the drugs that are anti-seizure drugs that we prescribe every day, they've all been tested in animal models, and I'm not aware of any drug that is effective in animal models of seizures that it's not effective when trialed properly in humans. So the translation in the epilepsy field has actually been very good. And one of the advantages we have over these other areas that I've mentioned is these animal models actually have epilepsy. They're not models of epilepsy, like your EEA model of multiple sclerosis isn't multiple sclerosis, but these rats have seizures. This is epilepsy. And so we actually are in a very good position in the epilepsy field as we have models of animals that actually have the disease. No one has tested yet whether a drug that's disease modifying in animal models is also disease modifying in a disease modifying epilepsy trial. So we really don't know the fundamental basis of that question that people are asking. But it's very important not to be too negative about animal models of epilepsy, because they have been, our field is one field where they have been very successful overall.
So actually talking about animal models besides using rat, how about other models like zebrafish or Drosophila fly?
I suspect this is from my friend Farouk, or he's So look, the first thing to say is I don't have any personal experience in these models, so I don't have the same feel for them as I do for the rodent models. I think the further you move away from a human brain, the more there is a chance that the findings are less relevant. I mean, ideally, we would be doing these studies in primate models, but of course, the ethics and practicalities and costs of doing that are very prohibitive. These models have advantages in that they are scalable in a way. The sort of experiments that I showed in the animal models, these preclinical trials, they take years, several years to produce results. You've got to follow animals for up to 6 months and do continuous EEG recording. It's very expensive and labour intensive, and very limited the number of drugs you can screen in those sort of models. So we do need better models to screen for anti-epileptic as opposed to anti-seizure therapies. In our group, through Bren Molo and Patrick and Tony Baker, we've set up a in vitro stem cell based screening assay looking for disease modification to try and screen drugs that would look promising in vitro, and then we can move them into the chronic epilepsy models. And it's very likely that models like fruit flies and zebrafish could achieve the same goal of narrowing down many different potential drugs to a limited number that you can then test in the chronic epilepsy models. But I don't think they're going to replace the predictive value of ultimately needing to do those preclinical trials that I've just talked about.
Yes. Thank you very much, Terry, for your sharing and answering the questions. It's because of time, we'll stop our Q&A here. And thank you again for all who has participated in this talk. Thank you very much.
Thank you very much for inducing me and for inviting me to be part of this excellent conference.
Thank you so much. We'll end the session here. Thank you both, Peter.
Bye all. Have a good day.
Thank you.